Welcome back to NBME 29. Today we're continuing with question 11. These are all original questions. Like and subscribe. So here, a 3-year-old girl is brought to the clinic by her parents due to concerns about developmental regression. She had a normal development until about 18 months of age, when she began losing the ability to speak and stopped using utensils or toys with her hands. Over the past several months, she has developed repetitive clapping motions and frequently wrings her hands together. Parents noticed her head appears smaller compared to other children her age. Physical exam, she has a blank facial expression, and she periodically hyperventilates. Which of the following is the most likely underlying mechanism of this condition? Okay, those are our answer choices. So this condition is Rett syndrome. It's a mutation in the MECP2 gene, which is an X-linked dominant mutation that's usually lethal in males. So MECP2, it's a critical transcription repressor that keeps the genes in check in the neurons. When it fails, the neurons can't mature normally. And usually this is going to be present in girls between about 6 to 18 months who are developing normally, and then they start to regress. So you should look for the loss of language, hand function, microcephaly, and also the hand wringing movements. There are also going to be some strange breathing patterns. And here's a more in-depth breakdown. Type repeat would be Fragile X. Deletion of 15q is Angelman's. Imprinting would be like Prader-Willi's. There you see obesity, hypotonia as well. And tumor suppressor loss is Lee-Fraumeni, not related to neurodevelopmental regression. So the big clue here is the regression, the mutation on MECP2 and the X chromosome is the answer. Okay, for our next question, we have a 76-year-old woman. She's brought to the emergency department for sudden onset, severe upper abdominal discomfort, and repeated dry heaving after a large meal. She's got intermittent bloating, difficulty swallowing, especially after lying down. She denies recent alcohol use or prior history of ulcers. Vitals show hypotension and tachycardia. Physical exam has epigastric tenderness and mild abdominal distension. A nasogastric tube cannot be advanced to the stomach. Chest x-ray shows large retrocardiac air fluid level. What's the most likely predisposing factor for this condition? And the answer is a paraesophageal hernia allowing gastric displacement. So when the stomach rotates on itself, it causes a rare and life-threatening emergency called gastric volvulus. You should think about it like a twisted balloon. The air and the contents just can't escape. And so you get what's called Borchards' triad. You have epigastric pain, dry heaving, and the inability to pass an NG tube. So there's that twisting and inability to pass. Now, what lets this happen? Most often, it's a paraesophageal hernia. It's a type of hernia where part of the stomach will slip through the diaphragm beside the esophagus. That kind of looks like this. We have our normal diaphragm, normal stomach, weak diaphragm, hiatal hernia, and here is our paraesophageal hernia. There's our paraesophageal hiatal hernia. So part of the stomach is literally slipping through the diaphragm beside the esophagus. And the clues that tell us it's an underlying chronic hernia condition would be that history of post-meal bloating and dysphagia. So that's why our answer is D. Trap answers, gallstone migration. There you'd have intermittent right upper quadrant pain and pancreatitis. Duodenal ulcer with fibrosis. That would present with chronic outlet obstruction. So in that gastric outlet obstruction is where you have persistent vomiting, early satiety, because there's a mechanical obstruction. And this is seen where causes of this are peptic ulcer disease, gastric cancer, and infiltrative diseases. You'd have non-bilous vomiting. It's associated with peptic ulcer disease, gastric cancer, chronic NSAID use, pancreatic carcinoma. It also has some infectious causes like TB. And all that's happening here is there's chronic inflammation or a tumor that causes a progressive narrowing of this pyloric canal you can see here. And so gastric emptying becomes impaired and you get retention of the gastric contents. That can cause vomiting, so you get a loss of hydronium and also chloride. And so you get metabolic alkalosis. And then the kidney will compensate and you get paradoxical aciduria. That's where you try to conserve sodium at the expense of hydrogen. So all this to say that's duodenal ulcer with fibrosis would be that condition. Malrotation with the Ladd bands is common in infants that would have bilous vomiting. And intussusception has the current jelly stools and colicky abdominal pain. Okay, next. We'll call that last one a bonus and we'll call this one 12. Here we have a 72-year-old male presents to the emergency department because he fainted while getting up from the toilet. He's got mild diarrhea for the past 2 days, not been eating and drinking. Well, he takes lisinopril and chlorthalidone for hypertension. Supine blood pressure is 132. After standing 2 minutes, his blood pressure drops to 98. What describes the immediate changes that occur when you're standing up? So I've drawn this person laying down and then standing up. There's less blood return, so it's hypovolemic state, causes less venous return, and there's going to be less of that firing because there's less blood to fire those receptors. And then that lack of perfusion of oxygen or increase of CO2 is going to cause cerebral perfusion to decrease. So this is hemodynamic orthostatic hypotension. This is seen in hypovolemia or shock states. You have decreased blood pressure and cerebral hypoperfusion. So when you stand up suddenly, then gravity pulls the blood into the legs, and that causes decreased venous return. And so you have a decreased preload. That decreases the stroke volume as you decrease the cardiac output, and that decreases the arterial pressure that's sensed by the baroreceptors in the carotid sinus and also the aortic arch. And the decreased baroreceptor firing normally increases the sympathetic tone, but here you have decreased parasympathetic firing. And so in autonomic failure, this compensation is blunted, and so you have cerebral hypoperfusion and syncope. Usually we describe this as a 20 millimeter mercury systolic blood pressure or a greater than 10 change in diastolic pressure drop whenever you stand. And the culprits that you'll often see with this are like your diuretics, alpha blockers, TCA, Parkinson meds, diabetes, that kind of thing. And that decreased cerebral perfusion comes directly from that decreased mean arterial pressure. When the MAP fails, then the cerebral blood flow will drop. And so you might have brain hypoxia, so you get dizziness, blurred vision, syncope, weakness. And the brain is just super sensitive to the drops in perfusion. For instance, even a 10 to 15 millimeter mercury drop in MAP can reduce the cerebral blood flow by about 20 to 30%. And that's enough to cause syncope in vulnerable patients. That's why they're typically going to be elderly, like the 72-year-old male. For this next question, we have a 39-year-old male undergoing evaluation for chronic mucocutaneous candidiasis. As part of the immune workup, he receives intradermal injection of heat-killed Candida. After 48 hours, a test site shows 15 millimeters area of induration with surrounding erythema. Which of the following is most likely the predominant immune cell type at the injection site? The answer is macrophages. So here we have a positive Candida skin test, very similar to a PPD test. They're both type 4 hypersensitivity reactions. The delay is driven by Th1 cell activation, and then that attracts your macrophages. Plasma would be type 2 and 3, phils is type 1, neutrophils are acute, not delayed. Natural killers would target the virally infected ones, but not the primary mediators here. So basically, if you inject Candida antigen into somebody's skin and you check back a couple of days later, then you're no longer testing just for a fungus, you're actually testing for the T cells, because that indurated hump at 48 hours is not pus. That is the result of a type 4 hypersensitivity reaction. And that is driven by Th1 cells and macrophages. So macrophages are the main effectors. They're recruited by interferon gamma from the activated T cells, and they release the enzymes and the cytokines that cause the tissue swelling and the firmness. So it's all about the cell-mediated immunity. Okay, next, this is an ethics lesson. We would all do well to listen and validate before speaking. So always think about patient autonomy, think about listening to what their concern is, ask them more questions about it. So we'll make up a question. This guy's got diabetes, type 1. He says, I'm not sure. All you've done is stick me once. And instead of saying just, trust me, I'm a doctor, or do you want antidepressants or something crazy like that, you just say, could you tell me about some of your concerns, or could you tell me what you think this is? Try to open up the conversation. Question marks are always a good thing. Patient anxiety often masks deep fears. So you have to have empathetic listening. Don't jump to facts without emotional validation, or else you can shut down the conversation. For this question, let me ask you, are these your rods? No, these are our rods. You guessed it. The next whose answer is acute myeloid leukemia. Well, you might come up with central pallor, thrombocytopenia, and that's what we've done here. A 35-year-old man has fatigue, easy bruising, nosebleeds. He's got some petechia over his lower limbs and mild pallor. Look at those platelets. And we have numerous large blasts with open chromatin and a few containing needle-shaped cytoplasmic inclusions, our rods. In your question, you might also have mentioned 15 to 17 translocation, increased risk of DIC. You talk about Down syndrome, where you have an increased risk of AML, or mutations in the myeloid progenitor cells. Could have mentioned the cytopenias, low HB, white blood cells that could be high, the CD13 positive on the flow cytometry. Basically, you could have gone a lot of ways. But acute myeloid leukemia is a clonal malignancy of myeloid progenitor cells in where? The bone marrow. Now, this is characterized by super rapid proliferation of the immature myeloid cells. Those are called myeloblasts. You get bone marrow failure because of the crowding out of the normal hematopoiesis. And this can happen at any age, but it's most commonly in adults that are greater than 65 years old, but any age. And what causes this is a genetic mutation at 1517. That's the APL subtype. That involves the PML RAR alpha fusion gene, and you treat it with all trans-retinoic acid. There are some risk factors to look out for on test day. One would be chemo or radiation. You can have therapy-related AML. Myeloid dysplastic syndrome. That can progress to AML. And then, of course, Down syndrome, especially if it's before the age of 5, can predispose you as well. And some lesser-known ones are the benzene exposure, smoking, industrial solvents, Fanconi anemia, Bloom syndrome, and other DNA repair mechanisms. But the pathophys for AML is very important. You have myeloid stem cells that acquire mutations, and then they start to just bang out all these immature precursors, and then those fail to differentiate. And so you get a bunch of blasts in the marrow. And that crowds out the normal cells. You get anemia, thrombocytopenia, neutropenia. You can't make stuff because the bone marrow ain't working anymore. It's too crowded. And so the blasts then start to spill into the blood. So you have an elevated white blood cell count and possibly DIC, at least in acute promyelolytic leukemia. So usually you'll see greater than 20% myeloblasts in the bone marrow. That's diagnostic for it. And then our rods, not your rods, are the red needle-like inclusions in the cytoplasm of the blasts. And also, importantly, you see MPO positivity on these stains. But that's probably too easy. They won't tell you that. Cool. That's question 15 in a nutshell. Now for this next one, we have a 65-year-old woman. She's brought to the ER. She's got fever, chills, productive cough for the last 4 days. Her sputum is yellow-green. She has pleuritic chest pain and mild shortness of breath. Temperature is 39, so 102.4 degrees Fahrenheit. Which of the following findings is most likely present? The answer is increased tactile fremitus over the left lower lobe. This is interesting because when pneumonia hits, the sound actually travels better because the lung tissue is going to be consolidated. So in lobar pneumonia, you're not going to block the sound, you're going to amplify it. So increased tactile fremitus and bronchial breath sounds. You can also have egophony, the E to A change sound. If you hear dullness to percussion and harsh tubular breathing sounds in the periphery, then that's a huge big red flag for pneumonia. So here are some of the buzzwords we talked about. Here are the associations. So pleural effusion would have decreased fremitus and dullness and decreased breath sounds. Pneumo would have decreased fremitus, but hyperresonance. That's super important for your tension for pneumothorax, air. And then lobar pneumonia has all three sounds increased. The pathophys is that there's an infection of the alveolar exudate that replaces the air with fluid and pus. That increases the conduction because it's consolidated, and the vibrations you can hear, and the percussion is dull. It's not hyperresonant because it's filled with fluid content. So yeah, the vibrations don't lie. Importantly, the signs of pneumonia are going to be like the cough, you get the fever or like some yellow sputum, stuff like that. Also, maybe they'll have some pain on the right side of their chest whenever they breathe in, and then they'll have like some sort of a fever. So you look at that and you say, oh my gosh, that's pneumonia. Pneumonia is going to have consolidation of that pus in the alveolar exudate. That air is going to be gone, so it's going to be consolidated. So all these sounds are going to be increasing on the affected side. So you have increased tactile fremitus. Does that make sense? If that made sense, then be sure to like and subscribe. Next, we're going to talk about the kidney. So there's a 68-year-old man. He's admitted to the ICU following septic shock secondary to peritonitis. He was hypotensive. Now on day 2, his urine output decreases. Which of the following nephron segments is most likely to show irreversible injury? And that's the proximal convoluted tubule. Now I want to do something fun on this question. First, I'm going to explain, but then I want to talk about how this applies to the rest of the human body. So we have ischemic acute tubular necrosis after septic shock. The proximal tubule is the most susceptible to that. It's the first site injured during hyperperfusion. And you can look at the iron sodium to confirm intrinsic renal failure. The collecting duct is also affected but less metabolically active than the proximal. It's less susceptible. Glomeruli, DCT, these are all less metabolically active and so not as susceptible. So the part that works the hardest is the part that breaks under pressure is the proximal. Now, with that being said, what are some other areas of ischemic necrosis and lesions that you can have? So we mentioned the proximal tubule, but a huge one is obviously going to be the brain. That's the most sensitive tissue to hypoxia and hypoperfusion. There you have irreversible neuronal injury that can happen even just 3 to 5 minutes out. And so the especially vulnerable areas are like the hippocampus, the Purkinje cells of the cerebellum, neocortex layers, that stuff. Also, the heart. Ever heard of a heart attack? It's kind of a thing, huh? So the subendocardium of the left ventricle is the most at-risk area. It's the furthest from the coronary blood supply and experiences the highest pressure during systole. Okay, now how about the intestines? There are some watershed areas that are vulnerable. One is the splenic flexure region. That's between the SMA and the rectosigmoidal junction. That's between the IMA and the hypogastric. It's poorly perfused, so you get hypotension and ischemic colitis in the elderly and post-op patients. Another big one is the retina. So those guys have high oxygen demand and there's no collateral flow. And so if you have central retinal artery occlusions, then you're going to have painless vision loss. No oxygen, central retinal artery is occluded. Cool beans. Okay, our next topic is going to be the sun. Mr. Sun came up and he smiled at me. So what is this crazy weird thing that I've drawn? That is a cholesterol precursor that's found in the skin. It plays 2 roles. And then 2, it's a precursor to vitamin D3. And it has to be exposed to UVB sunlight. So it's formed in the cholesterol synthesis pathway just before the cholesterol itself. And it plays a big role in vitamin D production. So in the epidermis, the UVB hits it. It converts it to pre-vitamin D3. And then vitamin D3, cholecalciferol, travels to the liver. And I'll write this down. And we get the activated 1,25-dihydroxy-vitamin D, which is calcitriol. And that's our active vitamin D. So skin, liver, kidney. And if you have kidney failure, then you have low active vitamin D, right? Liver disease. And then sunscreen will cause decreased vitamin D synthesis. And I think we're ready for a question. So we have a 16-year-old male, moved to California, spending most days skateboarding on the beach. He's got the juice. Okay, anyways, past 3 months, he's grown 6 centimeters in height, increased appetite and energy. Alkaline phosphatase levels are within normal range for his age. Which of the following is most directly responsible for his increased intestinal calcium absorption? The answer is the transcriptional effects of UV-activated dermal cholecalciferol. So that's the conversion of that 7-dehydrocholesterol and the vitamin D3 in the skin. That causes our active vitamin D, and that helps us get our calcium and phosphate absorption. So here's the pathway. Irradiation, 7-dehydrocholesterol to cholecalciferol, vitamin D3. Liver makes it into 25. Kidney, through 1-alpha-hydroxylase, converts it to 125. And we get the transcription of our channels, and that binds calcium inside of the enterocytes, allows more calcium to be absorbed. So there's a pathway from the sun to calcium in your body, pointing to me, or thank you, son. All right, this one's going to be super duper buzzy. We have a 70-year-old man presenting to primary care physician for evaluation of gait instability. His wife notices progressive worsening handwriting, difficulty rising from chairs, and hallucinations. They could also say cogwheel rigidity. This is definitely Parkinson. So what is the protein composition? The answer is alpha-synuclein. This is a memorization question. So what is alpha-synuclein? It is a neuronal protein that's involved in the synaptic vessels regulation and neurotransmitter release, especially dopamine, and it's found in the presynaptic terminals. And when it's misfolded, alpha-synuclein becomes insoluble and it can aggregate, and that'll cause Lewy bodies, right? And so this is involved in Parkinson disease, where the Lewy bodies in the substantia nigra, pars compacta, and I'll show you that. There we go. Here's the healthy. There's the substantia nigra, right? You lose that dopamine. And another one is Lewy body dementia, and that's in the cortical neurons. So that would be our Lewy body dementia. So if you look at alpha-synuclein, you think, oh man, one's Parkinson's, one's Lewy body dementia. Yeah, but it's multiple things, right? There's also multi-system atrophy. There are a lot of alpha-synucleinopathies. But the pathophys is basically you have alpha-synuclein that misfolds. It can aggregate into like Lewy bodies, and then it impairs neuronal function and survival. So look out for Lewy bodies and also Parkinson stuff, but the answer is definitely alpha-synuclein. Think of A for abnormal synapse, alpha. Okay, there is our explanation. I'll move myself out of the way so you can see. Lewy bodies, alpha-synuclein. Beta amyloid is Alzheimer's. Tau is Alzheimer's frontotemporal, so different changes in the personality. Lewy would have hallucinations, Lewy bodies. Prion protein associated with spongiform changes. TDP43 found in ALS. Okay, now for this one, we have a clinical trial. We're evaluating the anti-hypertensive drug utility. 40 patients in stage 1 hypertension are randomly assigned to receive either the new drug or a different one. 8 weeks later, we get the means, and we want to determine if there's a difference in the means. What are you going to do? Student t-test. It's how you compare the means of two things. Unpaired student t. Chi-squared, categorical data, male, female, dead, alive. Paired is when the same subjects are measured twice, before and after. ANOVA is for 3 or more, and linear regression predicts the dependent variable based on a couple independent variables. So a student t-test would calculate the p-value based on the difference of the means. This guy over here, you look at the difference between them, the standard deviations, the sample sizes, all that stuff, and if the p-value is less than 0.05, you reject the null hypothesis, and it means that this new method probably had an effect. Student t is 2 grouped means. Paired t-test is before and after. ANOVA is 3 or more, and chi-squared is for proportions. All right, guys, hopefully that was helpful. We just finished 10 more questions. Please be sure to like and subscribe if you found this interesting. Make sure you guys get your physical exercise in today. Just do 10 questions, take a break, stretch your legs, 10 more. All this will eventually change when AI fully infiltrates the medical field. But until then, time to memorize a whole bunch of stuff. See you guys in the next video.